Good morning. My name's Saihan. I'm from Glasgow, UK. I'm chairing this MSK sessions final day. There will be 3 speakers from Northern Hemisphere. We will discuss after all the speakers finish. So the first speaker will be Dr. Nicola Maholen. She's a radiology, nuclear medicine, dually trained consultant from King's College London, United Kingdom. So please switch off the mobile phone or keep in silence. And for CME session, you can use that app after each talk. Okay, let's start.
Okay, first I'd like to thank the organising committee for inviting me to come and talk to you about Charcot osteoarthropathy and lessons from our diabetic foot clinic. During this talk I want to go through the pathophysiology of the Charcot foot and remind you of the clinical presentations and some of the limitations that we've got regarding the pre-imaging evaluation and where bone scans and in particular SPECT-CT come into that. But what I'm not going to be talking about is the infected foot or the ischemic foot, and I think that there is a talk definitely on infection later on. I haven't got any disclosures. So one of the primary problems is that there isn't a consensus in the literature regarding the definition of Charcot foot. This has been slightly improved at the beginning of this decade when there was an international task force who agreed that Charcot neuropathic osteoarthropathy is a condition affecting the bones, joints and soft tissues of the foot and ankle, which is characterised by inflammation in its earliest phase. And this acute localised inflammatory condition leads to what we recognise as the destruction that happens in the Charcot foot, which is characterised by bone destruction, subluxation, dislocation and deformity in the later stages. And I think everyone will recognise that this patient's got a very abnormal looking foot and ankle. The ankle's clearly not aligned properly, and they've got secondary ulceration and lots of erythema and swelling going on close to the areas of the abnormal protuberances. You can see that they've got a classic rocker bottom foot deformity as we see in the Charcot foot. But what we're trying to really do, and I want to impress upon you in this talk, is that we're trying to avoid patients getting to this stage by early diagnosis. And what are the causes? Well, the diabetic foot, Charcot osteoarthropathy was first described, in fact, not by Charcot, but in 1703 by Musgrove, who described a neuropathic foot which became disordered in a patient with syphilis. And in the 1800s, it was called tabes pedis because it was much more related to syphilis than the current major cause now, which of course is diabetes. But any of these other causes of neuropathy can be associated with a development of Charcot foot. But as I was saying, it's diabetes which is the #1 cause these days. And we know that this is a multi-system disorder which affects the patient from head to toe with common complications of blindness, cardiovascular disease and renal failure. But I just wanted to draw your attention to the problems in the feet, and that every 30 seconds somewhere in the world has to have an amputation because of the complications of diabetes. So by the end of my talk, that's 60 people who have lost a foot. So we really need to try to draw our attention to this and see what we can do to help prevent it. And again, diabetes, this is data that's just been released by the International Diabetes Federation, who describing diabetes now as a global emergency. And that's because the incident rate is rising steeply. And these are their predictions. They're predicting that in the next quarter of a century, there's going to be around a 50% increase across the world in the levels of diabetes. And this is largely to do with the increasing obesity epidemic. And I was sitting in Federation Square the other day, and I noticed that there was a big poster presentation saying that 28% of Australians are now considered obese, and in bold letters, change it. But that's easier said than done. What can be done to try to reduce this epidemic? And this is the recent guidelines that have been produced by the American Association of Clinical Endocrinologists regarding the lifestyle therapy, and everyone kind of tosses around the words, do some lifestyle factors, and we know that means kind of lose some weight and do some exercise, stop smoking. But a couple of other things that they've added in, which I think is increasingly recognising the importance of sleep hygiene, increasingly recognising the importance of community engagement and having people not feeling isolated. And then regarding nutrition, something that's quite new that's been put into these guidelines is the recommendation for a plant-based diet, high in polyunsaturated fats and low in trans fats and fatty acids. So I think that's the first time that a plant-based diet has been recommended. So what are we trying to do? Well, as I was saying, we're trying to get to early diagnosis. We don't really want to be having to deal with the accommodation and correction of deformity, which is really more of a surgical thing to do. And how can we do that? We want to diagnose the Charcot foot when the X-ray is still normal, and that's when what we call Charcot stage 0. And with rapid intervention, we want to keep it normal. So no prizes again for recognising that this set of radiographs are grossly abnormal, with collapsed arches, destroyed joints. This foot's not going to be functioning properly, and they're going to result in having secondary problems. They're going to have ulcers on their protuberances, they're going to get infection from that, and this is the end stage. Little note there about vasculopathy. It's felt that the ischemic foot is relatively protected against getting Charcot because there's a difficulty in having the increased blood supply required for the inflammatory process to occur. But interestingly, if patients have had Charcot foot for a long time, then they can develop the vasculopathy as a secondary factor, which they think is to do with abnormal calcification released in the inflammatory process. So the clinician's faced with the patient, of course, the normal things, history, examination, investigations. And what is the history? Well, it tends to be a very short history. Patient says, I woke up this morning, I can't get on my shoe, or I was walking along, suddenly, I heard a funny noise and my foot started to swell up. And this really echoes with what Charcot said when he was first describing it. Overnight, there is enormous tumification of a member. And 1 or 2 weeks later, sometimes sooner, the existence of more or less marked cracking signs may be noted, betraying the alteration of the articular surfaces, which at this period is already profound. And just draw your attention, 1 or 2 weeks later, we haven't really got much time to stop this foot from going from normal to dysfunctional. Patient going to end up with lots of problems and going to possibly end up losing their foot. We need to act fast. Unfortunately, the patients often haven't really got any memory of recent trauma, and that's felt to be due to the fact that it does occur in patients with a neuropathy. But, sometimes you can tease out that they may have been more active than usual, or perhaps they've gone back to doing activities that they're unaccustomed to. And also in the history, you might as well find some other triggers, which would be previous ulcerations, surgery, or occasionally infection. And what's actually happening? Well, as I said at the beginning, Charcot foot is felt to be an inflammatory process. So the normal bone homeostasis is controlled by the Rankel pathway. And in the case of a Charcot foot, then increased inflammatory cytokines are released. This promotes or activates the Rankel pathway, which changes osteoclasts, pre-osteoclasts into activated osteoclasts, which causes lots of osteolysis. This is the normal mechanism for bone healing because this will be inhibited by the OPG pathway, but there's something that goes wrong during the activation by the Charcot foot, whereby this inflammatory process goes unchecked. Sorry, this slide doesn't present very well, but it's just to remind you, the big yellow square is the inflammation, but as well as the repetitive trauma, because the patient carries on walking on the foot, the other things that are feeding into this inflammatory process are the very element of hyperglycemia, which causes advanced glycolation products, which then feed into the inflammatory pathway, and also abnormal autonomic neuropathy, which promotes abnormal vasodilatation. And again, that's felt to be delivering extra blood and promotes the inflammatory process and also osteolysis. So just to show, we're looking at some severe disruption of the foot just by walking. And I think this patient wouldn't be too difficult for people to see that their foot looks very abnormal in terms of angulation medially and looks swollen and red. That's not a Charcot stage 0, clearly, because the X-ray also shows that there's clear disruption of the joints. We're trying to diagnose earlier than this, but the things that we're looking for in examination are a temperature difference of more than 2 degrees. You can imagine that a clinical sign like that's not going to be incredibly reliable, but that is the clinical sign which they use most often. And we're also expecting patients to have good pulses, but that can be a bit difficult as well when the patient's got such a swollen foot. But generally, as I was saying before, the ischemic foot's relatively protected. This patient, though, just looks like a puffy red foot. We can't see any obvious malalignment going on, and you can imagine that this is a bit more difficult to work out what's going on. So the take-home message is that you have to have a high index of clinical suspicion. A red, hot, swollen foot in a diabetic patient with neuropathy is a Charcot foot until you prove otherwise. What are the other things? Typical things would be cellulitis, DVT and gout. And a recent study has shown that 94% of patients with Charcot foot have been misdiagnosed in the primary and secondary care settings, resulting in more advanced Charcot osteoarthropathy. So we're really trying to raise awareness amongst the general medical community that we're looking at diagnosing early. One of the other problems is that it's not always that easy to work out if the patient's got neuropathy, because the large myelinated fibres are often relatively preserved, and that means they pass our clinical tests of touch, pressure and vibration, because it can be very selective abnormality in the small myelinated and unmyelinated fibres, causing the abnormal pain and temperature control. So you do have to have a peripheral sensory neuropathy, but you might not be able to find it very easily on clinical examination. Then you go on, of course, to anatomical diagnosis with imaging. Just a quick slide there to show you the Freyberg's classification of Charcot osteoarthropathy, which has looked to see where it tends to affect, and it most commonly affects the midfoot. And on the X-ray, you're looking for the signs of injury in the bones, the joints, and the soft tissues. This patient's got a clear Lisfranc malalignment there and abnormal vascular calcification, so this is not going to be a stage 0, but it isn't too difficult to make the diagnosis. But we find that the bone scan is very useful to look for acute Charcot arthropathy, because, as I was saying to you before, the clinical findings can be quite difficult, and if you're going from it as everybody's got Charcot until proven otherwise, you're going to end up having a lot of false positives, and those tend to be because of fractures, infection, gout and degenerative disease, as well as plantar fasciitis. And we're finding that using bone scans help us to improve this. So this is what we're looking for. This is a set of planar images with perfusion, early blood pool and delayed phase. And the left-hand column of images are pretty normal, and they go to become more grossly abnormal on the right-hand column. And we've got a little scoring system, but we don't really use it clinically. I'm not going to go too much about how we do our SPECT CT, because I think this audience knows about that. Just to say that we do use diagnostic CT. We do reconstruct on a small field of view and use an overlapping pitch, and then we display our fused images in 3 orthogonal views, as well as displaying on our packs the reconstructed CT images as well for the orthopedics. So this is an example of a patient you can see, and you'll, I'm sure, easily recognise very abnormally increased perfusion, blood pool, and delayed uptake in the midfoot, but also multifocal there in the forefoot at the tarsometatarsal joints, and there's clear evidence of increased focal uptake, which we could see was a midfoot fracture. That still is considered a positive Charcot stage 0. You can have a fracture and it still be a Charcot stage 0 if you've got multifocal uptake. If you've just got focal uptake because of the fracture, then it's treated as the fracture. This would be a negative study for Charcot, in that there be an alternative cause of plantar fasciitis. So I just wanted to tell you about the lessons from our foot clinic. We followed up patients presenting with a normal radiograph, but the red hot swollen foot, and we did bone scintigraphy on them with SPECT CT. We had about 127 patients who had 135 scans. We had a slight excess of patients with type 1 diabetes compared to type 2 diabetes. And in those, we found 85 patients were positive. And we included patients who had fractures in that, but who had multifocal uptake. And those patients were treated as a Charcot foot, and they were casted until the temperature normalised, which can be around 6 months. That's a long time to spend in a cast. And of those, we managed to avoid complications of Charcot osteoarthropathy in terms of going on to have more progressive changes. In nearly all the patients, 7 patients did have osteoarthropathy at the end of the time, but the other patients we had avoided, so that was a good result. The patients that were negative, what do we do with those? I think this is where it really comes into the fore. We found that they were treated, if they were, I'm saying they're SPECT negative because they didn't have the typical pattern, but they may have had some problems that we did identify, for example, a unifocal fracture or Freiberg's, plantar fasciitis, whatnot. They were treated as per the diagnosis, and nobody was casted for more than 12 weeks. And for those patients, we didn't have any cases of Charcot osteoarthropathy. So we find that the negative predictive value, well, in this particular study, it was 100%, but we always find that difficult to claim. But it does appear to have a very high negative predictive value. And the reason that we started doing bone scans as opposed to MR, which is tends to be more widely reported in the literature, was simply availability. And it was much easier when we were starting out to get the patients on the scanner, this was before SPECT CT, than it was to get them access to the MR, which we know we need to act quickly. And one of the other things that has been of great interest to the clinicians are, where do the changes start? Does it start in the soft tissue or does it start in the bone? So we went through and scored a number of our cases to see where we were getting the uptake, and sure enough, it did tend to be in a large number of patients at the ligamentous insertion. So this is an example of Liz Frank's ligament insertion. This is the bifurcate ligament insertion, tibialis anterior attachment, the deltoid ligaments, and the spring ligament. So there does seem to be some pattern going on, that it is abnormality arising at the ligamentous and tendinous insertions, but we also do get lots of uptake in the subchondral bone around the joints as well. So it's not purely a ligamentous problem. And as reflects really what the Freyberg's classification of where we get the abnormality. We found most commonly it was midfoot, really, where the ligaments were having abnormality. So going on to another example, here's a patient with a normal ankle radiograph, clearly very abnormal bone scan. I've only got the early blood port and delayed planar images there. I haven't got the perfusion, but that was positive as well. And we can see that there's grossly increased uptake in the talus, which relates to a fracture which couldn't be seen on the plain film. Probably could be seen on the CT if we hadn't done a SPECT CT, but I think it's quite subtle and probably would have been overlooked without the big bright red blob drawing our attention to it. MRI, as I said, this is more commonly used really in many centres, and the literature does support the use of MRI as well. And again, you can look for the early bone damage, looking for bone marrow edema, fracture and ligamentous injury. So this is an example of bone marrow edema. We can see abnormal high signal on the stir images. This one shows a similar thing, but we can also see the fracture line at the base of the metatarsal there. We can also look for the ligaments, and there's some high signal in the Lisfranc ligament there, but it's intact. Whereas in this one, we can understand that the Lisfranc ligament has become disrupted because of the midfoot dislocation. So what is the management? The primary management is casting therapy. There is some debate in the diabetes community about pharmacological therapy. Some people use bisphosphonates because they're trying to turn off the osteolysis, but I don't think that's universally recommended. The main thing really is the casting, and then if you haven't managed to control the problem, then you're going to go on to orthotics and surgery to correct deformities. But as I say, we're trying to avoid that. And this is the mainstay, as I was saying, old-fashioned, in a typical kind of back slab type of cast, or on the right we've got the more modern total contact cast. And you can imagine that it's not nice to be told you have to wear this for the next 6 months. So I think we've got a really important role to play to help the clinicians to decide which patients should and which patients shouldn't have to go through this therapy in order to save their feet. It works by immobilising the foot and reducing the abnormal mechanical forces that would otherwise occur by continued weight bearing. It reduces the edema and inflammation and helps to arrest the progression of deformity. So in our centre, we have a high clinical suspicion for the Charcot foot if it's a red hot swollen foot. First things first, put on the cast, then do all the rest of it. If you've got abnormal changes on your X-ray series, you already know you're at least at a stage 1. If you haven't, then you're at a Charcot foot stage 0, and you've got the chance of preserving this foot and preserving the function for this patient. So in summary, diabetes is increasing, and so is the incidence of Charcot foot. It's generally not terribly well managed in the greater community, so we need to try to improve that. We want to prevent deformity and ultimately amputation by early diagnosis, and we've got a role that we can play by doing bone scintigraphy and, where possible, SPECT CT to ensure correct patient management. I'd like to thank you for your attention and acknowledge the diabetic foot team at my institution at King's. Thank you.
Thank you, Nicola. That's a very comprehensive, very useful presentation. On behalf of the organizing committee, certificate of appreciation I would like to present. So we will discuss later after all the 3 speakers finish. So second speaker is from India, Dr. Riju Gopinath from Aster Hospital, going to talk about artifacts in musculoskeletal SPECT CT. Thank you.
Good morning, everybody. First, let me thank the organizers for their kind invitation. So then, thus we in last 3 days, we come across with plenty of applications of and newer advancements of SPECT CT and the newer areas of development of SPECT CT imaging. But we should all understand, so that the right perspective is the key word for understanding any impression. So, but when you get an impression, so then if you are not getting the right impression, so you are making a false judgment and different actions which is not correctly appreciated. So this is the importance of artifact. So then this artifacts in the imaging, so makes the final diagnosis accurate. The understanding of this artifacts are very, very important, even though it is very negligible or it is comes in random in your practice, but it is understanding is very important. So then this, as far as the specificity of the specificity as per the literature goes, it is from the 10%, it is from in this early 2000s. Now it has come down to 85 to 95% in various literature. So this the specificity, even though it is remarkably high compared to the planar scintigraphy, but we are still in short of than 10% what it was actually perceived in the beginning. So it is all attributed for the various artifacts which is incorporated into this the imaging scenario. So this it is a relatively, the old problem is it is a relatively new technology. So it is almost like a marriage between two individuals. So then they will have different personalities when it comes together. So it requires a lot of adjustment, alignment to make kind of a smooth progressive progress of the events. So then the CT as such have plenty of then errors and artifacts which we all know, and the SPECT itself has a lot of limitations. So when it combines together, then it then augments many of these issues which is actually perceived for individual applications and will become exceedingly apparent in the combination of SPECT and CT together. So that is the primarily this the MDP, as we all know, it is the blood flow and the extraction efficiency. It makes that whole MDP uptake in the osteoblast. So there is the osteoblast activity. So it varies in different pathologies, or in normal physiological conditions also attribute a lot of osteoblastic activity. So understand this normal then physiology is very important in identifying various artifacts. So this CT, as we know, say it is two major issues is with the CT is the accurate localization of the structure, and the second one is the attenuation correction issues. The SPECT, as we know, so there are plenty of issues associated with the SPECT image, we all aware about. That is the patient position, orientation, physiological status. And when you put together, then the generation of a third set of problems arises. So this generally, so the source of artifacts, we can put it into various categories, but for easy understanding, you can make into different titles, like in attenuation, radiopharmaceuticals, technical issues, instruments, faulty ingestions, air, contamination, traumatic issues, and various kinds of spots. Spots in the means, it doesn't mean hot spot, it can be also be cold spots. So then all the spots will also makes your interpretation in tilt into various directions. So coming into attenuation issues. So this coming into this simple picture. So this attenuation we all know then is a bladder CA patients. So you can see this is in this red arrow, so that is ileal conduit area, and you can see a cold area in this, that's a violet line, so that is corresponding to the pacemaker. So it's a cold area, so it's a typical normal is expected then attenuation artifact which we will come across in cardiac patients. So then, but the main problem with the attenuation which comes with this new generation, the transplants. So the transplant, because nowadays a lot of orthopedic transplants, the various metals, the implants, and the fillings, which makes the attenuation issues much more marked than in earlier days. So what is the problem happening here? So then the CT, when it is in a, then mostly the attenuation correction CT in this, most of the SPECT CT missions uses a low energy CT. So the low energy CT, when it passes through the high density material, so there's many of this low photons or the CTs will get absorbed, leaving only the high energy photons which is streaking through the side of the metal. That is the one side problem. Other side, the SPECT, it is almost like most of the gamma rays, because it is weak photons, it will completely get stopped by this heavy density metal. So when you have two problems, one is the low photons of the CT has been absorbed, and the second one is complete stoppage of the gamma images. So these two issues, when put together, it will create a lot of noise, because only the high energy CT predominates and will over subtract the photons or this attenuation coefficient, or it makes an error in calculation of attenuation coefficient of the soft tissue, which makes a lot of high energy CT photons dominate over these other photons, which will make a high energy CT streaks along the metal artifacts. So that's the spoiler in this in the problem with this then this metallic transplant. So you can see in this picture also. So you can, I hope you can see here, so then you can see the streak artifacts here. And this is a typical, so high energy photons has been then highlighted. And the second problem in the fusion image, you can see this shoulder joint. So around the process is the problem. So because it is adjacent, the soft tissue has been completely been absorbed by the metal, and this the low energy photons of the CT has been taken out. Only the high energy streaks of this the CT image has by overshadowed all the other photons. So when you take an image of one projection, so then you will get a lot of noise. When you reconstruct it together, so this noises get amplified, and finally it will make a big noisy issue that's called the streak artifact. So this to correct this issue, so plenty of applications, new generation applications. So then this, especially the Siemens has come up with this very interesting application. So it called the expect. So conventionally, so this CT and the SPECT, it has been corrected in a single platform. So when the CT, the reconstruction done, so it is done, it does completely separately in a kind of in a set of correction. And when the CT, and it makes a different kind of correction and in a calculation of attenuation coefficient, when you put together, so that it doesn't match each other, so then we'll create a streak artifact. But with this new system, the expect, which makes the SPECT and CT put together, and it makes a single matrix, each matrix to matrix, which makes a kind of a reconstruction algorithm. It creates a reconstruction algorithm for individual matrix. So the final image, it won't affect the problem separately calculated for attenuation coefficient from the total CT images. So this makes that images crisper. So then you can see this is the images from the conventional attenuation correction to the expect. You can see that it has been significantly, the borders of these organs have been significantly demarcated. So coming to the radiopharmaceuticals, so as we know, so the poor preparation of the radiopharmaceuticals will kill the day. So because all the patient, if you don't inject the patient without QC, then it will create a lot of problems in the stomach as well as the thyroid uptake, we all know. So the appropriate QC is very important for injection of the radiopharmaceutical, especially when this radiotracer is prepared in the morning, and if you inject in the dose, then without doing QC, after 3-4 hours, there will be a deterioration of the quality of the radiopharmaceutical product. So then another problem is the dialysis patients, because there is a lot of aluminum and colloid formation which can produce a lot of soft tissue and will leaving very poor availability of the radiopharmaceuticals into the skeleton, so which will make this images very nasty. So other technical problems. So the technical problem, the main problem is about the patient size. That is one of the patient size on the soft tissues. That is the main problem. So this it is the same principle as of the attenuation correction. So then there are a lot of the noise will be generated, because you can't just make a lot of dampening of this photons both in SPECT and CT, which will make that the image is much more noisy, and it can happen from anterior posterior as well as side to side. In both sides there will be a problem. And this is a typical example. So you can see this is a normal person, and you can see this is an obese person. So you can see here, then the photons have been attenuated, so which will make a lot of the noise in the images, and you can see if there's a noise of images on the side fourth also. You can see because of the liver attenuation, so you can see the lot of truncation artifact happening on the side. So this is another serious problem, because you may, if without having a history, then you may be forced to make a statement that is the limb is missing, but it is a photo PMT tube defect. So then that is it is evidence you can see in, from the both images. It is just because of the one PMT, one limb is missing. So then up or down. This is again is a very common issue. So then most of the SPECT CTs patients will to keep their head up for the whole body imaging, because that is a normal way of taking out the arms into the field. But the problem is, because since it is a prolonged procedure, if the patient have the shoulder problem, so the CT will be acquired when this head's on the upright position. But while taking the SPECT, the technologist or because the patient voluntarily put the hands down. So then suddenly there is a kind of an object which comes into this side, which can make a lot of then over correction, over subtraction of the photons from the hands which it is keeping down. So this is a big problem. So there's and always have a track on or observe the patient when the patient is keeping the head down, or from the images itself you have to get an idea whether the patient is having the hands down and up in different then keeping different positions during CT and SPECT acquisitions. So another problem, so then here then you can see there's a kind of uptake here, so you don't know what exactly it is, so then there's a problem, so you may call it as in May kind of a skeletal uptake. But if you carefully, then if you just carefully just see, so you can see this is the hand of the ingestion side, the hand which has kept a proximity to the patient. It has been changed during acquisition. So during anterior and posterior acquisition, so there is a kind of a shadowing effect which has come, so which will create a kind of artifact, and you may or may not be tempted to call it as positive. It depends upon the area of artifact appearance. Another problem is about this, the typical, it's not a technical problem, it's a technologist problem, because they generally does the patient positioning on kind of things. They are handling the patient. So then if you have then catheter, and if you are, it is placing close to the tibia, and if you are not removing it properly, so you may not able to really appreciate what is exactly happening. So you may call it as significant sometimes, depends upon the position of this artifact origin. So then there's a proper positioning on the bag as well as the tubes are very, very important to avoid artifacts. Another, sometimes you will see an uptake like this, but you should be very careful. It should be a muscle uptake. So then if you are suspicious, it's a bilateral symmetrical, so there is something. If the patient's a long bedridden patient, so then there's a kind of uptake which is seen on the muscles, which can be easily excluded in this, then additional image. So additional image is, again, it is very important. So the instruments, coming into instruments, so there are plenty of movement-related artifacts. Then, so if this patient is moving, as I just mentioned earlier, so on various positions, if you have the patient during acquisition, if it is voluntarily or involuntarily. Voluntary means, then because of the uncomfort of the patient. So you have to be properly position the bed, and you have to make the patient comfortable before acquisition to get a good image. That is mandatory. And the second thing is involuntary, which you can't do anything. So it can be cardiac movement, it can be a diaphragmatic movement, or it can be peristaltic movement. So the natural movement, so that's a voluntary movement again. So then you have to take it into account. So, and you can very clearly see, and equipment, against what I mentioned, is nowadays in most of these centers, nobody uses the low dose CT equipment associated with the SPECT, because everybody uses the higher energy CT. But in the early days, and many centers still following, it's a low dose CT, but it's a big, big problem for making the correct attenuation, calculating correct attenuation coefficient, because it takes thicker slices, which takes out a lot of details in both in CT as well as the SPECT images. The faulty injections, as we all know, so the injection appropriate, you have to put a cannula and inject. In the direct IV injection is ideal, but then you should always practice injecting in through IV cannula, and because it will avoid a situation like this, because when the tracer, when it is localized in the lymph node, it will completely spoil the situation. So then you may tempted to sometimes you may tempted to call it as significant, because you may say it is a rib uptake if you don't have associated corroborative evidence. And this kind of situations are actually the SPECT is really coming to help in your in a clinical dilemma. But it could have been avoided very easily by giving an intravenous injection through a catheter. So that is very important. Air, as we know, the air in this lungs and the diaphragmatic movement is a big problem. So benign artifact, it is well known, and we all come across in everyday practice in PET CT. So this another problem is about the misregistration because of the diaphragmatic movement, the air movement, the diaphragm movement, so which creates a lot of kind of then up and down movement of this both the CT in the SPECT images. But if you acquire a breath hold CT, and then the SPECT you can't do about an acquisition in 20 minutes time, so you can't keep the breath hold for 20 minutes. So then when we take these two techniques together, so you naturally you can expect a lot of misregistration issues, which most of the software, most of the systems, it will be accommodated, but still you will see plenty of kind of if the patient breathing, if the COPD patient breathe excessively, and you will have a lot of this kind artifact which is erased from this diaphragmatic movement. Another problem is typical. So then this, you see there are two lesions here on the sagittal view. So then, but the proper reconstruction, you see only one image. It's all just because the chest movements are excessive. So then you will see, and you will appear as two uptakes, then two lesions, two rib lesions, but it actually is a single lesion because of the excessive rib movement creates a kind of an impression about two lesions. Contamination. So we all know contamination is the one commonest reason for creating artifacts, but and you should always you can corroborate with this then you can do a lateral view, additional view, or a SPECT image, or you can check the chance remove the clothes and recheck, and all those things you can try. But a potential problem, so you may with this image you can easily you may call it as an inferior pubic ramus involvement, especially the patient who has see a prostate on rising PSMA. But it is a penile activity and the urine drop which is touched on the body, which creates an artifact. Traumatic, another problem. So then this trauma, occult trauma, it is kind of a stress fractures. You can see this is end of sacrum, the coccygeal region. There's a kind of a stress fracture which may not be apparent in this the planar image. So you may easily miss, but in the spectra shows because spectras taken because of the excessive low backache, but clearly show there is a traumatic stress fracture associated, which causes the pain. It is the pain cause for the patient, but looks apparently normal in the planar image. So the spots. So hot or cold, it is very important. It is not mandatory be the hot spots to create a false positive impression. So it is all because of the fundamental reason. So the calcium the metabolism in the body is very complex. So it is not necessarily associated with the skeleton. There are a lot of then a degenerative process, the normal aging process. There's a lot of pathological post injection. Post chemotherapy or post operative period, there are plenty of ways then this calcium get localized metabolism and produces a false positive MDP uptake in these various places. So then you can see here is a pleural effusion. You can see here is a pleural effusion. It's just because of increased capillary permeability. So because it is nothing to do with the malignancy, because of the high hyperemia, the tracer which has been leaked into the thoracic component of this collection of fluid, and which makes kind of then haziness in the thoracic region. Again, typical problem is this pendant, the ornaments and all those things you must remove. Then otherwise you will see then in the blood pool phase, if you remove, then you saved at least that cortical images to make a false positive impression. And you can see, so this is the pacemaker. Again, it is again pendant, which is, you can see here, it is creating a false positive. It's creating a cold area, which can, which is actually, so it is very tough, or it is inappropriate to make a statement there is something which is an artifact is there which we didn't care while during acquisition. So you should always, whenever there is a kind of an artifact which has been documented or visualized by the technology, it is make them as their responsibility to change then artifact and to reacquire to get a correct image, because that is the right way of him then conveying a good report to the clinician. So again, so this prosthesis, then again, so history is very important. If the patient is on prosthesis, you have to see a respiration post-mastectomy, always check whether the prosthesis is been placed. So then here, then you can see a small area of calcification around the prosthesis, which can produce kind of a false positive impression, or you can create a confusion while making a report if you don't know the history of the prosthesis implanted in the patient. So other problem is about this calcification within the tumor. So if this sometimes see a lung patients, you can see it's a cystic mass lesion. So then with a high growing end, the speculated lesion. So then this will attract a lot of calcium deposition. So it will make kind of it's a non-case of malignancy, but you can see this around this lesions there may be calcification which may mimic something in the ribs or somewhere, so which we are not sure. So then this kind of problems are, you should aware about then as a potential area of artifact while making a report. So then this another problem is the metastatic deposit, as the primary tumor itself or the metastatic deposits as such. Sometimes it will attract a lot of calcium, so it can produce spotty deposition. So it can exactly overlay over the ribs, which can make a kind of impression about a positive finding if you don't have a corroborative the SPECT CT with you. And then if you see this the uptake in this the parenchyma, you are safe. You make you are making the patient into completely then less dangerous so on than making a very ominous statement. So coming into the another area, so this is it is not always the lung. So sometimes the hepatic tumors also attract any tumors, not necessarily the lung or liver. So any tumor we can on long term on degenerative process can attract calcium. So this calcium deposit in the hepatic tumor which can produce a kind of uptake here. Another problem is the patient, again it is showing the importance of, the history. So the patient is a transplant, then post-renal transplant, it shows that kind of uptake here. So then it is exactly overlay on the celiac bones, but it's a typical site, but, then it should be aware. Then the patient is already had a transplant, because the kidneys both kidneys are absent here, the kidney renal activity, and, the excital position of it matches with the typical iliac fossa for a renal transplant. So another problem is something in the pelvis, you are not very sure, but the spectators clearly gives a conviction about a stone in this bladder. So that again, it is it gives a big relief for making a kind of ambiguous statement. So sometimes this is sickle cell anemia patient, so then the splenic infarct and the calcium deposits, so it can produce a kind of linear uptake along the ribs, which can sometimes you may tempted to make a kind of a report out of that, but then you should aware that in a sickle cell anemia patient, you should always aware that there's a potential threat of splenic infarct come into the picture, make a false positive impression about the skeletal deposit. So the pitfalls again, so what we are all talk about this, then artifacts, but you should aware about this, the normal physiology, the variations which can come across in the normal skeletal scintigraphy, which can make some erroneous judgment. So then always you should see the myeloma is one area, so we should be very careful if the potential of combination of myeloma into other malignancies is also there on long term. So there are a good chance for patient is getting kind of completely normal study, irrespective of extensive skeletal involvement is very much there. So there's multiple myeloma in the case of multiple myeloma or suspected case of multiple myeloma in other known malignancy. So you should be careful about making a statement, because because there will be a lot of false negative cold area will be there. So then a SPECT will give potential identification of all this the lesions which can be easily identified through the CT screening. Other one is the post-chemo response, which can last for the 3 to 6 months. So then you should be aware. So then it can produce kind of a completely hot skeleton without having any kind of a actual the progression of the disease. So then while making a judgment on the post-chemo patients, you should be always careful about this post-flare response can be last for almost 6 months. That doesn't mean so the patient is not regressing. So that is a very dangerous statement if you make. So that is should be very much aware about the chemo flare response. And other thing is sometimes you will see completely everything looks perfect, but then you can see there's a kind of an uptake here, then this in the iliac blade. So then is something which is very strangely it is uniform and very simple, subtle, but it is there. So it is nothing but enthesopathy, tendon then calcification. So then it is again it is sometimes this especially the athlete or kind of person so is working with a lot of movement with the hip. Sometimes the enthesopathies become more evident. So then those patients you may see a kind of a normal uptake. So this is a different kind of uptake pattern in this call. You will see diffuse uptake in post-menopausal region, women, so then without chemotherapy or hormonal imbalance. Even sometimes even completely normal biological biochemical profile, you will see a variation like this. But but again, so then you can make a statement there's a kind of a metabolic dysfunction which may be corroborate with their actual physiology in post-menopausal women. This is a usual pattern. So the metastasis is always patchy and non-uniform. And now you will see this tunnel phenomena. Again, it is a normal one. The segmentation, again, it is a normal variations. That broad lower part of the tie appearance, again, it is kind of it's a normal variation. So all these are all normal variations. So the kidney uptake different. It is an obstructed kidney, one side, both sides, and a nephrocalcinosis post chemo. So then is again it is chemotherapy induced. Then secondary then hypermetabolism. Other situation is then you can see a kind of a diffuse uptake, and you don't know whether it is metastatic or not. So, but then you have to always the cortical thickening and there's excessive sclerosis, patchy sclerosis, which confirms that is a kind of a Page's disease. And it's not metastasis. So again, it is a kind of a diffuse ascites which can produce then attenuation of a lot of tissues behind. And in the hemangioma, again, it is very, very important. You should always, it's a potential very common. So you will see a lot of hemangiomas and will have various type of calcium depositions which can produce a false hotspot. So you should have exact characteristics identification of a hemangioma. And sometimes this is a problem. So in a small lesions, you will have a diffuse diuretic changes and a cold lesion. So you may miss a cold lesion, which can be almost 15%. You may identify in the laminar process or in the pedicle region. You will have an isolated metastasis. So again, this is a kind of a chondroma. You can see this is a benign pathology. We have a positive uptake, but it is nothing to do with this metastatic. So you should know the ring calcification of a chondroma, and that's a normal one. The DRIT spots, you can see. So the final take-home message is the artifacts are very common, and it is randomly creep in your day-to-day practice, and you should have a very clear idea on this the problems which is associated with the artifacts. So it is attenuation, proper attenuation correction, because then you should urge for getting the newer software. It is not the newer equipment. The newer softwares are plenty of softwares available both in CT and SPECT reconstruction. So you can, in the previous days also it was been highlighted. So you have to urge for getting the newer software for the proper attenuation correction. The QC testing is the key for this, getting minimizing the artifacts, and this the positioning, the proper positioning, and the breath holding pattern, the breath holding CT acquisition. Again, it is important for then minimizing the CT related attenuation error. Periodical QC of the equipments, again, it is mandatory. And this intravenous injection always through IV, not direct. So then this contamination should be marked in images. If there is a contamination, it is make it as a duty and responsibility of the technologist to mark it as a contamination instead of making a guesswork later. So careful history, that is the trauma, surgery, implant, and chemotherapy. This is the careful, the mandatory, make it as a checklist before in the history examination. And the potential for extra ossification, extra versus calcification has to be well identified. So then that should be, we should be very much careful and we're being aware about this, the potential problem of calcification. Thank you for your attention and thank you very much. Good day.
Thank you, Dr. Raju. Very comprehensive. There will be a lot of overlap. Before you go, on behalf of the organizing committee, I would like to present a certificate.